Okay, well, thank you everyone for attending this evening or late afternoon, wherever you may be. Welcome to our Ask the Experts Live, the coffee talk with a gastroenterologist. My name is Chris Rich. I am the CEO and Executive Director of the National Celiac Association. I welcome you here. This is going to be a light and casual conversation in regards to just answering some general questions and getting the expertise of our expert who is on with us today. This webinar series provides, like I just said, intimate and casual conversation environment. And it's complementary piece to what we have on our website, which is our Ask the Experts Q&A section. That addresses hundreds of topics and questions that's related to celiac disease and also gluten sensitivities. So tonight we've received many questions. I thank you so much for sending those in for us. But if we don't get to your question tonight, if it's not addressed, be sure you check out that Ask the Experts section on our website. It's at nationalceliac.org/Q&A. You can find answers to many questions there. Just there's a search button. You can type in, if you have a word, just say, let's say medications or whatever. You'll see the articles that pull up for that. So use that resource. Some housekeeping things before we get started here. For this event, you are welcome to ask general questions through the Q&A feature. That's located at the bottom of your Zoom screen at the menu that pulls up. You'll see a Q&A box there. Please note that this is an educational webinar. There's no information here that's going to be intended for diagnosis or treatment of any medical condition. Seek the advice of your physician or other qualified health providers with any questions that you may have regarding a medical condition. So these are going to be just general. So when you think about your Q&A and what you're putting in there, if you can keep it at a general level, that would be most helpful. Also, this webinar is being recorded and it's going to be available for viewing on our website at nationalceliac.org. So without further ado, I want to introduce our expert for tonight, Dr. David Limauro. As you can see here, David has extensive credentials that he's going to and he's going to share his expertise with us tonight. He's a medical staff member at St. Clair Hospital in Pittsburgh, the physician and co-owner of the South Hills Endoscopy Center, also in Pittsburgh, and an active member of many different organizations, including the American College of Gastroenterology, the American Society for Gastrointestinal Endoscopy, Pennsylvania Society of Gastroenterology, and Crohn's and Colitis Foundation of America. He is also one of our medical advisory board members here at the National Celiac Association. So I am going to hand it over to him and say thank you, David, for participating tonight.
Oh, thank you. Thank you, Chris. And thanks to the NCA for having me tonight. It's my pleasure to be here. And I'm going to share my screen now. And hopefully, yes. Chris, thanks so much for having me. I mean, because it's January and the calendar has just turned, it got me reflecting a little bit, and actually made me realize that I started my gastroenterology fellowship in 1995. So I'm now on my 30th year of gastroenterology. So it's a perfect time, I think, for me to hopefully help some folks with the insights and things that I've learned about celiac disease in the last 30 years. I look forward to sharing what I know. I have no pertinent disclosures, and what I'm going to do is flip through about 8 or 9 slides that I've made. I've got a small presentation for maybe 15 to 20 minutes, if that's okay, and then Chris, you and I will do the Q&A, if that works for everyone.
Yeah, we'll do your presentation. We'll take some questions that have been sent in before during the registration, and then we'll address some questions that come in during our talk tonight.
Perfect. So, who am I and why am I here? Sort of all the general CV stuff you can see here. But I think what's most interesting maybe for people is down at the bottom. I finished my GI fellowship in '98 and went into private practice. I'm an adult gastroenterologist. I've been with my practice for 27 years or so now. But when I first started out in 2001, I live in the North Hills. My practice is in the South Hills, and I have about a 40 to 45 minute drive every day to work. And like a lot of physicians, I do continuing medical education, and what I tend to do is listen to lectures. For years, I've been doing it in my car as I'm driving along. And when I was just out of training, I had a service called Audio Digest, and we didn't have podcasts back then, believe it or not. But I had CDs, and I would get a CD every week from Audio Digest subscription and listen to it riding along in my car. And one day back in the fall of 2001, there was a lecture by a guy named Dr. Alessio Fasano, and he was talking about celiac disease. And at the time, I believe he was at the University of Maryland at the time. I realize he's in Boston now at the Harvard hospitals. But Dr. Fasano was talking about celiac disease. And as a young gastroenterologist, I thought I knew a little bit about it, but mostly to me, it was babies coming off the breast, starting gluten in their diets, bloated baby, bloated belly syndrome, diarrhea, and, a few adult patients I'd probably seen up to that point, I thought, with diarrhea and maybe weight loss, sort of classic GI symptoms. But the more that Dr. Fasano started talking about it, it started to send off light bulbs in my head, because he was talking about looking outside of the GI tract, looking for atypical symptoms. And of course, he said, be careful of the patient with irritable bowel syndrome. And I was like, check, a lot of people, myself included, I think, have irritable bowel, lactose intolerance. Yeah. But then he said a few other unusual things. And one of them that caught my ear was, he said, look out for the patient with recurrent aphthous ulcers, or ulcers in the mouth. And I was like, huh, I used to get these terrible ulcers in my mouth. And I thought, well, I'm under stress, new job, young family, hustling to try and make partner or whatever it was. I thought that's interesting, but maybe whatever. And he went on to talk about a number of other symptoms. And one of the things that caught my ear again was, he said, watch out for the patient with a very low cholesterol. And at that time, I had an insurance physical or something done, a life insurance physical, and my cholesterol came back at 115, which is very, very low. And I actually told my wife, I said, honey, I think I'm going to live forever. I've got a really low cholesterol. This is great. Well, the more Dr. Fasano talked about the atypical symptoms, the more it hit me that, wow, this sounds like me. So I went ahead and I got an antibody test, a blood test at the time. It was an endomysial antibody. I don't think my lab even had TTG back then, tissue transglutaminase. I went on to have one of my partners do a biopsy, an upper endoscopy with biopsies. And our pathologist, this is 24 years ago, they looked at it and said, yeah, it's inflamed, but, it was a little equivocal. So I actually ended up sending it out to Dr. Fasano and his people at the University of Maryland. And he was nice enough to get back to me. And I remember his words, and they were, welcome to the club. So I've been a member of this club for about 24 years, and I think I can bring some perspective as not only a gastroenterologist, but ironically enough, a celiac patient myself. So what I'm going to talk about a little bit, my first slide, these are my 4 children. My wife and I had 4 children. And of course, what comes up when people are diagnosed with celiac disease is, well, what is the likelihood that my family might be affected? My children, my brothers, my sisters, my parents, those would be first-degree relatives. And generally, what the literature tells us and what I tell my patients is it's around 5 to 10%, and maybe in siblings, some studies as high as 20%. But every family is different, and I am a big fan of testing first degree relatives, that again, mom, dad, brothers, sisters, and children, following the ACG guidelines and many other guidelines. But in this picture, 2 out of 4 children have it. So it's not 5 or 10%, it's 50%, right? And it just brings the message home that there's many other factors besides just genetics. There's, of course, the diet we grew up with, the exposures maybe to viruses, maybe to pets, maybe it's our microbiome. There's many other things besides just genetics. And I think, one thing I've learned is celiac disease kind of always surprises me. Just when I think I've got it down, you get a surprise. So family testing is maybe something we can even talk about in the Q&A, but that's one point that I did want to bring across. I really like this slide, and the point that it brings across is that this is a autoimmune um, um, multisystemic disease. It affects not just the yellow box here, not just the GI symptoms, but almost all organ systems of the body. And the NCA has a nice diagram on their website as well. Then you can roll the cursor over and see which organ systems are affected. And I would recommend people take a look at that. But I just wanted to make the point that I think most gastroenterologists and internists and family practitioners and advanced patient providers in general medicine, we're pretty good, I think, in general, at finding celiac patients who have symptoms in this yellow box: diarrhea, weight loss, a lot of bloating and GI symptoms. But honestly, I don't think a lot of providers are very good at finding celiac disease when there are non-GI symptoms. And just in my own experience in the last years, I've found many patients who have, for instance, iron deficiency anemia. We know that this is a common presentation in the United States and elsewhere for celiac disease. People aren't necessarily presenting with the classic GI symptoms. They have atypical symptoms and lab abnormalities. And because we absorb iron in the first part of our intestine, the duodenum, iron deficiency anemia is very common. Another one that I've personally seen and diagnosed just in the last couple of years several times are people with mildly elevated liver tests. And when you think about it, the intestine, our intestine, the first place that it drains is in the liver. I tell people that in celiac disease, it's almost like there's a little fire burning, there's inflammation, there's irritation. And that immune system is also, those immune cells, those inflammatory cells are being drained directly into the liver. So it's not a huge surprise. It shouldn't be that liver tests can be elevated. And this is one that's missed a lot, in my opinion. When people go on to the gluten-free diet with celiac disease, those liver tests frequently get better. And I have one more, and my partners kind of kid me about this one, but I diagnosed one patient, a woman that came in for colonoscopy, and she had a terrible rash on her posterior, and she had complained about it. And the minute I saw it, I knew it wasn't a typical rash. It was actually dermatitis herpetiformis, a celiac of the skin, if you will. And sure enough, we did the appropriate testing, blood testing, and she ended up having celiac disease. So that was a patient that I had diagnosed sort of at the beginning of colonoscopy with celiac disease, sort of an atypical one, but kind of a humorous one. But I keep going back, in my career to Dr. Fasano's lecture and some other great papers. Here was an excellent paper by some other leaders in celiac disease that talks about the extraintestinal or the symptoms outside of this yellow box for celiac disease. I just wanted to speak about the tools of my trade. One of the most critical tools of my trade is upper endoscopy. And essentially what that is, as most people probably know on this call, is we're using a flexible scope with a light on the end that allows us to carefully examine the esophagus and the stomach and the small bowel. And this scope also has a channel within it, which allows us to do biopsies. And here I'm taking a biopsy of the small bowel. And it's a very, as I say, it's a key tool in my toolbox as a gastroenterologist. And, there's almost nothing that anyone could say to me that would dissuade me from wanting to do an endoscopy on an adult patient who's a celiac patient, except in maybe extreme circumstances. And I know in pediatrics in Europe, they're going away from endoscopy in children, but I don't agree with that at all in adults. And we can talk maybe a little about that in the Q&A. But not only is it because it's so critical that we get this diagnosis right. As almost everyone knows who has celiac disease, it's not an easy diet to follow. It's a lifelong diet. It makes things difficult at times. We have to get the diagnosis right. And for me, that means getting the tissue diagnosis as well and confirming the diagnosis correctly. But in addition to that, we find many, many other things. And I think I listed about 12 other diagnoses here diagnoses here that any gastroenterologist is going to find when they do an upper endoscopy, things that we can find easily in patients. And when you think about it, these are very common in our population. GERD, or acid reflux, is 30% of our adult population, and maybe half of those people will have erosive esophagitis or sores in the esophagus that we can find. 1 or 2% of the US population has Barrett's esophagus. That's something that we can find very easily on endoscopy. Eosinophilic esophagitis, or EOE, is, as I was preparing for this talk, actually it turns out it's also a disease of the immune system, an overactive immune system, and its incidence is increased in people with celiac disease. This is another thing we can find frequently, as well as many other things: hernias, ulcers. I just want to say a brief thing about H. pylori, or Helicobacter pylori infection. Extremely common worldwide, 20–25% in the United States, they say. Maybe not in our population and a suburban population, but very common and a cause of cancer and ulcers. So my point is that upper endoscopy, critical tool, not only for confirming celiac disease diagnosis, but also helping us find many other diseases that can be very important for patients. This is actually, these are the classic findings in celiac disease. This is the duodenal bulb, or the first part of the duodenum, and it's kind of nodular here. You can see the kind of, it looks a little bumpy. That's kind of classic. And here in the second panel is scalloping or fissuring of these folds. And this is kind of the classic findings. And I took this within the last month. I did an upper endoscopy on a 67-year-old woman who was diagnosed with celiac disease about 3 years ago. And she had been doing very, very well. Now, she admitted that, she had indiscretions. She would go out to eat a lot. And she said that she could eat. Sometimes she admitted that she was eating things with gluten and she would never get symptoms. But then within the last 9 months, she started getting terrible symptoms, pretty severe diarrhea intermittently, progressive symptoms, had lost about 25 pounds. And her daughter-in-law, who was a nurse, brought her in to see me. And I did, of course, take a history and an upper endoscopy. This is someone we would say who has non-responsive celiac disease. They'd been on a gluten-free diet for, years, and now they're not responding. They're having symptoms. So the question is, what was going on? Did we have the wrong diagnosis? Was she inadvertently getting gluten? I mean, she had been on the same diet for 3 years and not having a problem. Was there another disease? And, we took the history. I took the history, and it turns out she had a blood disease, P. vera, or polycythemia vera, and her hematologist had started her on a drug, Besrimi, which I was not familiar with, but I looked it up. And what it is an interferon, a pegylated interferon, which really primes up the immune system. So what was happening was she got a drug that amped up her own immune system, and it was attacking her gut. So we talked to her hematologist. We got her off of the interferon. I have her on some budesonide, which is a mild steroid now, and she's improving. But I think that it sort of brings home the point that, again, history is very important, particularly in these people who develop a loss of response or are non-responsive. But again, I'm always relying also extensively on our biopsies, on looking, because sometimes a person's symptoms do not correlate with objective findings. So again, I think the scope in these sorts of cases is very critical. I want to talk about the thing that my kids used to ask me, Dad, why? Why do we have to do this diet? Why? What's the point at times? A lot of frustration. We know that there's some things in the pipeline, some exciting drugs coming up, but as of now, the only treatment for celiac disease is a strict gluten-free diet, a lifelong gluten-free diet. So, why do we have to do that? Well, we know that there are, resolution. One of the reasons is, of course, the GI symptoms go away. The symptoms go away. And I've had patients myself who have had diarrhea for years. We make the diagnosis of celiac disease, and within a few weeks, their diarrhea can be gone. Now, that's the literature tells us that it's probably 80% of symptoms at 8 weeks, or it takes a couple of months in many cases, but most of the symptoms will go away by a couple of months. We know from research that's been done, large surveys, that quality of life on multiple levels gets better. We know that, people with celiac disease have malnutrition. They cannot absorb nutrients well, and particularly in the case I was talking about iron. If you can't absorb iron, they become anemic, but many other nutrients. So we can prevent the malnutrition that occurs and the maldigestion of not only vitamins, minerals, micronutrients, macronutrients. So that's critically important. Hopefully, in children, preventing delayed puberty and growth. And osteoporosis, which is very common, as we know, in our adult population, Caucasian females particularly, as they get older, high risk for fractures. And people with celiac disease, it's even that much higher. And if we can prevent that from occurring, those weak bones and fractures, that's very important. I think another sort of exciting thing is there have been several studies in adults, and I'm not sure about children, but I believe so as well, that going on a gluten-free diet may prevent other autoimmune diseases from coming. We know that these autoimmune diseases group together, and by going on the gluten-free diet, we know that adults who go on the gluten-free diet at earlier ages have less autoimmune diseases later. Things like Sjogren's disease, thyroid disease, Hashimoto's, autoimmune hepatitis, rheumatoid arthritis. There's many diseases. And of course, that's no guarantee that people won't get another autoimmune disease. But boy, if we have the possibility of preventing other serious diseases, that's a very powerful reason, I think, to be on a gluten-free diet. The last points here, I know this is the cancer word scares people. And, people, I think generally with celiac disease, in my opinion, I think patients tend to overestimate the risk, which is good. I'm not saying that there's not risk, but in medicine, we talk a lot about relative risk. And I think that's confusing for people because there's a big difference between relative risk and absolute risk. Absolute risk is your chance in your actual chance of getting the disease. So if my chance of getting a rare disease is 1 in a million, that's my absolute risk. It's very small. But relative risk is compared to another population. So let's say, Chris, for instance, you smoke 3 packs a day, for instance. Not that you do, but if you did, your relative risk for this disease that's 1 in a million, your relative risk might be 10 times higher, but it's still only 10 in a million. And that's a point I want to bring home in talking about lymphoma in people with celiac disease. Even though their relative risk is 3 times higher, the absolute risk is still very, very low. And the reason I have this diagram up is it turns out, even though I realize this is for inflammatory bowel disease, people with Crohn's disease and ulcerative colitis, I see a lot of patients with Crohn's disease and ulcerative colitis, and it turns out that their risk when they're on some of their medications like Remicade and Humira and others, their risk for lymphoma is about the same as a celiac patient. It's about 3 times higher the average risk. So the larger sand color, light colored oval, which hits about 9 people, that's an increased an increased risk of 3 times, relative risk 3 times higher than the average population, which is in the brown small box, which is 3 out of 10,000. But my point being here is that in celiac disease, the risk of lymphoma is only 9 out of 10,000 people every year. In 1 year, your risk is 9 out of 10,000. And the great news is if you go on a gluten-free diet, the studies tell us that people who go on a gluten-free diet after 1 or 2 years, your risk goes back down to the small box, down to the regular population, or 3 out of 10,000. So again, these, even though we talk about relative risk, and that sounds a little scary, you're 3 times higher, you're 5 times higher, the absolute risk of these rare diseases, a small bowel adenocarcinoma is a very rare disease. The absolute risk is quite small. So the point I want to bring home is, I think it's important to understand absolute risk versus relative risk. And absolute risk is what I try to talk to my patient about, to try and ease their fears a little bit. But it's also critical for these other reasons to follow, obviously, the gluten-free diet. Lots of good reasons. Um, let's see here. Oh, and I'm trying to get to my last slide. Come on. And this is my last slide. I sort of think of celiac disease almost like a medical chameleon. And what I mean by that is, chameleons, they can change with their surroundings and they can be hard to see, they can be hidden from plain sight. And celiac disease is a little bit like that as well, because so many of the symptoms are outside of that yellow box, that GI box. It can be hard to find in some cases. Even though it's in our plain sight, the diagnosis can be hard to find. Also, like chameleons, at least in the South, not this chubby guy, but other chameleons are certainly common in South Carolina and Florida, and celiac disease is very common. So I think the thing that, again, I want to go back to 30 years in gastroenterology. I think I've picked up a lot of pearls, but one thing is that we have to think outside of that yellow box of GI symptoms. And that really goes back to that lecture I heard even in 2001 from Dr. Fasano and others since then. But hopefully those are a few points that may lead to some questions and I hope can be helpful for some people out there.
Yeah, Dr. Limauro, thank you so much. I mean, there's
Sure.
a lot of the questions we've gotten in, I mean, you've touched on here in your presentation, which is awesome
Great.
to see. I'm going to have you stop sharing your screen so we can hop
Yes.
onto a conversation there.
Yeah.
But really, one of the things that I found interesting is I love that chart that talks about relative risk. I think that
Yes.
really puts things into perspective. I mean, you talk about, you hear the numbers, it's 3 times, but then you look at
Right.
what that really means.
Yes.
It's a nice perspective slide. One thing you did say I wanted to touch on, and it's a question that came into us, and you had a talking point about it. And I was talking about you had how you said most of the symptoms, you can see a reduction of those symptoms within a couple of months. But we have
Yep.
somebody who wrote in and said, why do I get more sick now if I get exposed to gluten compared to when I was first diagnosed? Is that
Right.
something that because the body is healed, or what is there an explanation for that?
Yeah. Yeah. That's a good question. I think, um, I think there's a lot of possibilities for that one. I think that um, the question comes up a lot, is it that the immune system somehow, when it gets a break, and then gets re-exposed after a prolonged period of time, is the response even that much higher? Is there a rebound is really the question. And I don't think I know the answer to that for sure. Do we
Mhm.
expect, more intense symptoms after we've been off of the diet for a long time? There's just so many other things that can also cause GI symptoms. So when people, and myself, my family included, when they get some symptoms, Dad, is this the celiac? And many times it's other things. Could it be lactose, intolerance? Could it just be, good old, people get viral gastroenteritis once a year? Could it be other could it be intestinal, bacterial intestinal overgrowth is people who have more severe symptoms. But, I don't know. That's a tough one. I really don't know the answer to that. I mean, um, let me think about that as we go along, and I'll see if I
Yeah.
could come up with a
No, that's
little
fine. I
something
didn't.
even better.
Yeah,
Yeah.
I'm just because we had questions come in about people asking, will this normalize? Is this something that'll go away? And I think we
Yeah.
talked about it, but it's there's
I, Yeah, and I would just say, obviously the goal is being strictly gluten-free, and we obviously all want to avoid it. But the reality is, we know that people are getting gluten. Unfortunately, I was actually listening to one of the prior talks that you did. I think it was with Dr. Leonard, and she was talking about the gluten immunogenic peptides, and that these are small peptides that they can detect in the urine and the stool. We're not using them clinically yet, but in research studies, and I looked online, you can get them, but a way to detect gluten. And we know that people on a strict gluten-free diet, it was detected in a high number of people. They're finding these poorly digested gluten peptides. So even under the best of circumstances, is my point. My point is that we're still getting some gluten. Many of us, as hard as we try, if you're going out to restaurants, likely you're getting some gluten. But it's not the end of the world. We do our best. We don't think very tiny bits of gluten is probably not hurting us in any significant way.
Mhm.
So I try to tell people not to get too excited about that if it's possible. I know it's easy to say and hard to do, but
Yeah.
yeah.
Yeah. Okay. One question we get a lot, and I think it's an area that people are, there's some they don't understand is that when we talk about silent celiac disease
Yes.
and the systematic effects of that on the human body, is
Yeah.
that something that you can define for us for a little bit?
Definitely. Yeah, I'm glad that came up because that's something I think about a fair amount is silent celiac disease, and even I'll also talk a little bit about potential celiac disease. But silent celiac disease occurs when a person has a positive antibody test, usually tissue transglutaminase or another antibody, and also a small bowel biopsy is done, an upper endoscopy is done, and the small bowel does show injury or enteropathy. Those villi, those beautiful villi, are flattened. There's damage to the small bowel. So you've got a person with a positive antibody and a positive small bowel test, but they don't have typical GI symptoms: diarrhea, bloating, gas, weight loss. And those are the groups that are called silent celiac disease. But I think that I don't like the term silent because if you really talk to them, many times they will have other symptoms. These are many times silent celiac disease is diagnosed frequently when we're looking at first degree relatives. We're doing a case screening, I guess you could say, or we're looking for cases in first degree family members, a brother, mom, dad. Well, I don't have any GI symptoms, and yet we find a positive antibody and a positive small bowel biopsy. They don't have typical GI symptoms, quote unquote, silent celiac disease. But when you talk to them, they say, oh, yeah, I do have joint pain, or I do have this rash that I've had on my face that hasn't gone away for, 3 years. Or maybe neuropsychiatric symptoms, brain fog, headaches. And I think that, it's been shown in these studies when you do put people with quote unquote silent celiac disease on the gluten-free diet, their quality of life does improve. And these symptoms that they may not have realized that they have will frequently go away. So yes, I do think celiac patients who have quote unquote silent celiac disease, really, when we drill down on the history, many times it's not so silent. They may not have GI symptoms, but they may have other symptoms outside of the GI tract. They should be treated, in my opinion. That's our recommendation that follows the guidelines. Um, but I want to kind of contrast that a little bit with potential celiac disease, which we also find a lot when we screen family members, mom, dad, brothers, sisters, and we find a positive antibody. But when we go down and do multiple biopsies, 4 or 5 biopsies from the second portion, biopsies from the duodenal ball, multiple biopsies, there may be no intestinal injury. The small bowel looks good or it's minimally inflamed. And we call those people potential celiac. Maybe they may get full-blown disease in the future. They need to be watched, I think, pretty carefully. And I would say that if we have a potential patient with celiac, but they have symptoms, we would treat them generally on a gluten-free diet. But potential celiac disease, again, positive antibody, negative biopsy with no symptoms, we would not treat, unlike the silent patient who has a bowel injury has a positive antibody and small bowel injury on the biopsies. I hope that makes sense. I hope I didn't, you know,
No, it
I hope
does. It
that's
does. Thank
clear.
you for answering that. So,
Yeah. Yeah.
one other question. We got this question in around IgA markers. We also had a question come in while we were speaking
Okay.
about kind of the same topic. And the question being is that, what could potentially be the cause of those IgA markers still being slightly elevated
Yes.
after like 3 years on a diet, or
Yeah.
the
Yeah.
cross contact's not a factor, numbers have gone down, but there's still a weak positive.
Yeah.
Um,
Yeah.
and in that case, is a biopsy being done again going to be helpful in any way?
Right. I like that. That's something, that comes up. And I will be quite honest. I have done my own TTG at times and it's been mildly elevated. And I'm like, darn it, I'm really trying really hard here. So, I mean, the first thing is, yeah, I think again, could there be inadvertent gluten intake? I mean, that is one possibility. And I think, again, with Dr. Kelly and his talk with Dr. Leonard, when they were talking about these little probes, the gluten immunogenic peptides, the super duper probes from the urine, we know that even people on the strictest diets are probably inadvertently getting some gluten. So that's one possibility. The other thing we have to remember is that these TTG antibody tests, they're not all the same. The sensitivities, every lab is a little different. And what I would say to that person if they're frustrated and they're like, why is this had one thing that they might try and do is go to a different lab. The assays are different between different labs. So some are more sensitive than others. It might be interesting if he's going to a LabCorp or a Mayo lab or a Quest, maybe go to another lab and see if see if you get the same result. Are we still getting a positive or not? And then I think the last thing that I would think of is there persistent mucosal damage going on? Yes. Is there still ongoing, small bowel injury? And that's why the tissue transglutaminase is positive. And I think if I'm getting the question right, in this case, frankly, yes, if it was my patient, would I do an upper endoscopy? Yes, I would do an upper endoscopy and biopsies for sure. I'd want to know how does that small bowel look? So and I would be curious, had that patient, I wonder, ever had a second endoscopy, maybe at a couple of years, to see if their small bowel injury, their enteropathy had healed, you know?
Hmm.
But I think that's a really good question. It comes up a lot. I've seen it many times. And those are the three, I would say those were the three big things that I would think about: inadvertent gluten, sensitivity of the lab, and maybe switching labs and see every lab's a little different, and then persistent mucosal damage. Yeah.
Yeah, we have a lot of questions about follow-up care and
Okay.
follow-up on after your original biopsy.
Yes.
As a gastroenterologist, how often do you feel once somebody's been gluten-free and done that, how often do you feel that they should be followed up with by somebody such as yourself? And what kind of tests would you typically run with them
Right.
once they're diagnosing going forward?
Sure. I think early on, I like to see people 6 months after I've made the diagnosis, and then probably at 1 year. And then at 2 years, I like to do a repeat biopsy in adults. And I think every 1 to 2 years myself. I know other people would probably say 1 year, but honestly, in my population, we live in, I'd say, a nice a suburban population, and people are I'd say they're well educated, they're busy, and I think once they get into the diet, every 2 years is pretty reasonable. 1 to 2 years, um, a little more early on, 6 months. I mean, realistically, I'm not going to tell you 3 months because we don't do that. I mean, it's really 6 months in my practice and then a year. And I think that I do like to check blood work. The tissue transglutaminase antibody I do follow usually 3 to 6 months and continue every 6 months until it normalizes is what I personally do. Annually, I'd like to see a CBC, a comprehensive metabolic profile, which basically has your electrolytes, your liver tests. I'll check a ferritin. I usually check, I'm pretty big on checking iron. It's of interest to me. I want to watch iron, particularly if someone is iron deficient, iron, TIBC, ferritin. 25 hydroxy vitamin D in Pittsburgh. We're all vitamin D deficient, so we check that. B12, I'll check. But again, realistically, does it have to be done every single year once people are stabilized, once they've been on the diet for a long time? Probably not. I think every 2 years is pretty reasonable. I know our guidelines, I think the AC guidelines probably say 1 to 2 years. But realistically, once someone is stable, I think every 2 years, that's what I personally do. I'll check a bone density at 1 year.
Okay. How about other testing? I know the question came in like, when can you stop having colonoscopies? And is
Yes.
there any relation to, is it different if you have celiac disease? Should
Yeah,
you do them more often? Yeah.
yeah. The good news is that colon cancer is not increased in celiac disease, so the screening is the same. Uh, and of course, colon cancer, number two leading killer of all cancers for men and women. So extremely critically important to get that to get tested. And I think a question that comes up a lot is when can I stop being, having my colonoscopy? I saw that one come across. And yeah, most of our guidelines for average risk screening, we stop at 75, although I would say there's a difference between somebody who's had, no polyps and somebody who's had, five polyps every 5 years. We will continue to do surveillance generally after age 75, from 75 to 85, assuming, it should be individualized, essentially, assuming the patient is well. And I would also say that although we screen up to 75 and older, we do it case by case. And
Hmm.
if someone's life expectancy is less than 10 years, I mean, I've got 65-year-olds who have severe lung disease and heart disease. I mean, they shouldn't be having a colonoscopy at all. So, I prefer a more individualized approach.
Okay. We've had some really great questions come in. Thank you, everyone, for sort of sending it in as we talk. I'm going to address some of those now
Good.
with you, doctor. So there was somebody who wrote in, my daughter at age 25 was confirmed with celiac 5 years ago through an endoscopy. And she says stress has a worse impact on small intestine bowel flare-ups compared to eating gluten accidentally. Is there a connection between chronic stress and celiac flare-ups or other GI flare-ups?
Well, yeah, I mean, I don't know if there's ever been a study specifically looking at small bowel biopsies in with a stressful situation. I know there hasn't been a study looking at that, but there have been some studies in acid reflux, for instance, in GERD, and they look at symptom scores related to stress. And we know that psychological and social stress does affect the gut, and GERD symptoms are higher. Irritable bowel symptoms are higher. So certainly, I mean, the brain and the gut are intimately connected, and stress is going to increase GI symptoms. So I think, does it cause small bowel inflammation? I think that's maybe a little bit of a stretch. I don't think we know the answer to that, but certainly stress causes GI symptoms. Yes.
Okay. Do you see a lot of dual diagnosis with celiac and IBD?
Um, a lot, I wouldn't say a lot, but because we follow a big IBD cohort, I have a lot of patients with Crohn's and ulcerative colitis both, and I can think of maybe just a few patients with both. Now the risk is increased. Your risk of Crohn's disease and ulcerative colitis is increased when you have celiac disease. But in my own practice, and I'm pretty aggressive, as you can probably tell, about screening for celiac and looking for celiac. And I can't think of that many patients that have dual. I do have, many patients who have thyroid disease, Hashimoto's. RA Sjogren's is a big one that I've seen a lot in people with celiac, but actually being unlucky enough to have Crohn's and celiac, fortunately, not that common in my practice.
Okay. Okay. Yeah. Here's one that came in, and I'm interested in this. I don't know if there'll be an answer to this, but I haven't heard of this. But someone said my celiac disease seems to be triggered around the time that I entered menopause. Is this common or on the more rare side? And if so, do you suspect why?
Yes. I have seen events trigger celiac. I can think of several things. People who have had, I can think of a woman that I saw. And actually, she was, I believe, she was from Finland, and she was a very athletic, super athletic. She was like on one of their Olympic teams or something like this, and she was in the United States, and she had her first child, and she was completely fine before the pregnancy, but after the pregnancy, she developed, significant symptoms, and we ended up diagnosing her with celiac disease. I can think of a gentleman I had who was like 85, and he had a major surgery, and he had been fine until he had, I can't remember if it was bypass or an intestinal resection or what it was, but it was a pretty big surgery. And after that, he had developed a lot of symptoms, and we diagnosed him with celiac disease. And my point is that there have been people who have major events in their lives, medical events, having a baby, having a surgery, and develop celiac disease, or appears to be a trigger. Now, obviously, they have the right genes, and they have the gluten that they're getting exposed to. They have the right environment, but many times there's another trigger as well. Viral infection, whatever it is. And I don't know, maybe menopause was her trigger. I have not personally seen that before. I don't remember reading about that as being common. Maybe others have, but that it may be that those hormones were her trigger when her estrogen dropped. It was her trigger. She was obviously genetically susceptible and was getting gluten, and that was it.
Yeah, and I think we had another question come in. It sounds like kind of the same situation where someone had been on a strict gluten-free diet for 14 years. After they were diagnosed, in the past 9 months, they've been having recurring respiratory asthma symptoms.
Mm.
Had complete testing done. Everything had been clear except for inflammation, and so they were wondering about a possible relationship between celiac and their asthmatic episodes. But it sounds like there's probably other triggers there, like you just said.
Absolutely.
Yeah.
Yeah.
So, okay. I want to go back. There's another question that came in. We were talking about silent celiac, refractory celiac disease. Are those with refractory celiac disease still at an increased risk for comorbidities despite having the completely gluten-free diet?
Oh yeah. I mean, okay, so I want to just differentiate between sort of non-responsive and refractory. In fact, I wonder if I have a couple of slides. Can I share my screen on that very
Absolutely.
quickly?
Yeah, you can.
Yeah, okay. Because I thought maybe this might come up. Oh boy, let's see here. Uh, Let me, this will just take a quick second. Um, so, non-responsive celiac disease, right, would be folks who have persistent symptoms despite being on the gluten-free diet. Like we were talking about, sort of my patient. Oh darn it! We were talking about my patient who had the polycythemia, and she went on the interferon, and after being gluten-free, something triggered her. But the question, with people who are not responding, do we have the right diagnosis? Um, could there be another condition, or another drug that's maybe triggering them? Interferon, maybe Benicar, almost certain that, the drug that's used for blood pressure, maybe that's causing a celiac-like condition. Um, are they inadvertently getting gluten? And then refractory sprue, though, that's a different category. That is a cause of non-responsive celiac disease. And let me show you another slide here. I think this might be from Dr. Leffler, who I know you had on one of your talks not too long ago. And this is, I think, from his study. But what it shows here is this idea of non-responsive people who are on the gluten-free diet but still having symptoms. What could it be? Well, a third of them or so are inadvertently getting gluten, right? Some of them, maybe they have microscopic colitis. We see that a lot with celiac disease. Some of them maybe have lactose intolerance or a disaccharide deficiency. Some of them have irritable bowel syndrome. And then a very small little piece of the pie, 10%, have refractory sprue, refractory celiac disease. That's a very specific small slice of this pie. Very serious, though. There's two types of refractory celiac, refractory sprue. I don't want to lean too far into it, but type 1 Generally, they still have multiple types of lymphocytes and they tend to do okay. They do a little bit better, low risk of lymphoma. They're treated with diet and a steroid and other things. These type 1 refractory patients do well. But the type 2, this is very serious. They have essentially a monoclonal, they have their lymphocytes have taken off. They essentially have a lymphocyte cancer. They're at very high risk for a very a specific kind of enteropathy associated T cell lymphoma. It's a very, very serious disease, this type of lymphoma. Now, this whole category is 1% of people with non-responsive disease. I believe, I'm sorry, type 2s are 1%, a very, very small percentage. In 30 years, I've seen one patient with this, and I don't want to see it again. It's terrible. I'm sure my colleagues at the referral centers at Harvard and Columbia or whatever, they're seeing maybe a little bit more of this because they're being referred the most difficult patients. But so I'm not sure that question, you might have to rephrase it, but when they said, are there risks of refractory celiac disease? Yes, of course. That's one of the worst things that could happen would be refractory celiac disease. A type 2 refractory celiac disease, which again is very rare, it is very serious. It's associated with very poor prognosis, frankly. But again, in 30 years, I've seen one, I
Mhm.
mean, that's pretty darn rare.
Yeah, the question, I think are those with refractory, are they at an increased risk for those comorbidities versus somebody who is
Absolutely.
not, who is
I
just on
mean,
it?
yes. I mean, that's
Okay.
a yes. If you have refractory celiac disease, that's a very yes. They're at high risk of having problems, especially type 2. I mean, it says 50% of those people will get a T cell lymphoma. Yeah,
Yeah. Okay. All right.
yeah,
We have time for just a couple more questions. Time flies when we're having fun here. So there's a question about healing, and do you know if it takes longer to heal if you're an older patient? In terms
right,
of, yeah, and how would you, if you have an older patient versus a younger patient, are you looking for different things when you see that patient?
right. Yeah, that's a good question. Well, we know. Yeah, in terms of adult population, like someone 30 versus someone 55 or 75, I don't think there is a great difference. I think it probably varies from individual to individual and the vigor of their immune response. Now, you might say, well, as we get older, we know that, our immune system maybe is not as vigorous. But, in adults, I mean, generally, it does take a long time for the small bowel to heal. We don't go back at 6 months and check even a year. Many times people will not be healed completely at a year. We many times will wait 2 years before we do biopsies, although I have done them at a year as well. Um, so I'm not convinced that a 70-year-old should heal that. I don't think it would make a clinical difference. Even if they heal more slowly, it would probably be, it's not clinically significant because we're not looking anyway until 2 years, generally 1 or 2 years. And I just don't think there'd be a difference between a 70-year-old and even a 35-year-old. Yeah.
Okay, okay.
Yeah.
Last question I have in this one came in with the registration, and I think it goes back to you were talking about we touched on genetic testing, and
Yeah.
we touched on touched early on families, and this one is really, are there tests to perform on the babies when the mom and dad has celiac disease? Is it just still a standard blood test, or are there different tests that can be done at the younger age?
Right. Well, genetic testing would not be the thing at this point because as we're doing HLA testing, and these genes are basically just permissive, HLA DQ2, DQ8, and 30% of the population has these genes. So doing genetic testing for them, most of that 30% of the population is never going to have celiac disease. So, going back to my slide of my own kids, celiac disease it's more than just about, the genes. It's multiple factors. So at this point, no, genetic testing wouldn't be appropriate for that. So as far as I know, and again, I am not a pediatric gastroenterologist, but no, it's still antibody testing at this point. Now, will that change in the future? It's very possible. Things are always changing. And I wanted to give a shout out to Mary Neville, who sent me an email about AI and the changes in celiac disease. And, certainly, yeah, I think that AI probably will be changing what we're doing in a few years from now.
Mhm.
Certainly in drug development, to Mary's question, it's going to shorten the time. We're going to see more drugs in the pipeline. They're going to get approved, hopefully, or get into trials more quickly because of AI. And probably we'll be learning a lot too as clinicians, which is what I am, not a researcher, but a clinician. We're
Mhm.
going to learn a lot of things probably from AI as well.
Yeah, and we just put out our magazine, the Gluten Free Nation magazine came out, and in that we had an article about the events that we were able to see at International Celiac Disease Symposium, and there were probably three or four AI focused discussions, and
Yes.
I was extremely interested. I sat in on all of
Yeah.
those, but just talking about how it is used to kind of speed up processes to remove
Yes.
potential human error in some of the situations, it's not a complete, this is going completely to AI, but it can be used as a complementary resource tool
Absolutely.
as this is going
Absolutely.
on. So
I'm a
yeah,
fan of
that was a good question. We saw that one come in. So yeah.
Yes.
So, Doctor, thank you so much. I mean, you've been able to field these questions that have come in. We appreciate your time in doing so. I know, you're a very busy person, and for us to just have an hour of your time to be able to, address these questions that our community has is, I think that's above and beyond for you. So, thank you so much for taking part.
Thank you for having me. It's my pleasure. I have to say, I think every day about celiac disease. I am happy to talk about celiac disease. It's a bit of a passion, so I'm happy
Okay.
to help.
Okay. Wonderful. And for everyone out there, if we did not get to your question that you sent in, again, please make sure to go to our nationalceliac.org website, go to the frequently asked questions, or I think it's nationalceliac.org/Q&A. You'll be able to find answers to many questions like the ones that we discussed here tonight. So go visit that site, and hopefully we'll be able to help out that way. So, but again, to you, Dr. Limauro, to everyone who attended, thank you for your participation in this event, and have a wonderful evening.
Thanks, Chris. You're welcome.